So what I'm going to do today is basically provide an overview of palliative care. I'm going to talk specifically about the mental health aspects of it because I am a psychiatrist. Right now I'm a consultant psychiatrist for the Temi Lettner Center at Mount Sinai Hospital. So some of you may know this is a program that sort of goes out to people in their house. There's about 22 docs or so who cover most of the city of Toronto, actually, and will do home visits to patients and take care of people from a palliative sort of perspective. I'm sort of their psychiatrist consultant. I facilitate groups to help them deal with the issues that they're facing. Plus, every once in a while, I'll run out into the community. To me, the community, I get to say that it ends at about Bloor Street. So, WHO definition, perfect. So 2002, an approach that improves the quality of life of patients for their families facing the problems associated with life-threatening illness, prevention and relief of suffering by means of early identification, impeccable assessment, treatment of pain and other problems, physical, psychosocial, and spiritual, okay? So there's a bunch of stuff that I want to emphasize in this definition, right? So life-threatening illness can be anywhere along the spectrum of the illness itself. A lot of people think palliative, you're dying, right? Right at the end stages. That's actually not true. This is one of the barriers that we're actually facing quite a lot these days. When, for example, I do in-hospital work as well, I won't get a consultation from an internal medicine person until the person is like a week or two from dying. And then I kind of go, well, what am I supposed to do with this? The person's a week or two from dying, right? You can't really do quick psychotherapy in a week. You can, but it's very limited. So I want us all to think about the idea of the spectrum of when we can introduce the notion of this. Because when we're talking about the idea of dealing with pain, pain occurs all the time, right? It occurs throughout the spectrum of illness. Pain is not limited to the idea of physical pain. Pain is a full spectrum sort of pain, right? We talk about the quality of total pain. So total pain encompasses physical, psychosocial, spiritual as well, right? So I think it's really important that we have an emphasis on the idea of psychosocial, spiritual, right? Medicine is very good at dealing with sort of physical pain. You may or may not agree to certain degrees. But a lot of times in acute care medicine, what we do is we focus on sort of the physical symptom, that's taken care of. Okay, our job is done. That's very untrue. There's so much more that needs to be done in terms of the comfort and the care of the patient or the person. You can tell I come from a medical model. I sometimes use the idea of patient instead of person. There's so much more that can be alleviated in terms of suffering. So this is one of the slides that I wanted you to see. So what this is basically a rectangle with a line through it, and there's another little tiny triangle there, basically. On this axis, we're talking about intervention. On this axis, we're talking about disease progression. Okay? So if and this triangle represents palliative care, this triangle up here represents curative intent. This triangle, this line is somebody dies, and this is bereavement afterward. Okay? So what I want you to take away from this diagram, again, is what I just repeated, what I just said. The idea that anywhere along the spectrum of the disease progression, you're going to have a mix of both curative intent and palliative care, okay? So, for example, if you're thinking about somebody with cancer, and they say have very widely spread metastatic cancer, it's in their bones, it's in their brain, it's everywhere, and the person gets a pneumonia, right? And they're suffering because of the pneumonia. Are we going to let them die because they have a pneumonia? Well, sometimes, if we talk to the family, if we talk to them, yes, that's sometimes the decision that gets made. However, we can also treat them the pneumonia, right? We want to alleviate suffering. The person's obviously suffering because they're physically ill. If we can deal with the problem and improve the quality of the life that they're having or improve the length of the life that they're having, hopefully both at the same time, then we're going to do that, or we're going to try to do that. Okay? So that's what I want you to sort of take away from this slide mostly. The idea that both can function simultaneously, both can operate jointly as long as you're talking to each other and as long as you have a very clear discussion about what goals of care are. We're going to talk about goals of care in a minute. Okay. The other thing that I want you to get away from this slide is this idea of sort of bereavement, right? When we think of palliative care, a lot of people focus on the entire system that's going on, right? We're not just talking about dealing with the individual that has whatever illness they have. We're talking about the system. We know that illness affects the entire system, right? We know that it affects the caregivers. We know that there are these concepts, for example, about burden, not wanting to be a burden, not wanting to create more problems for their family. We know that there's these ideas of people caring for other people, right? And if we have any sort of empathy and we're sort of a half normal human being, hopefully, we know that when we see somebody we care about in pain, we probably feel as much or more pain, right? So we want to be able to think about the caregivers as well. We want to be able to think about the people who are at that point in the curve sort of surviving, and we want to consider aftercare as well for those individuals. So some of the characteristics I've already sort of talked about. It's applicable to any disease stage, basically. The earlier the intervention, the more accepting people tend to be. The problem with this is as soon as you mention the word palliative care to most people, oh my God, I'm not dying. I don't want to talk about death. Who wants to talk about death? Who in here has a will? So, about 4 or 5 people out of the crowd? Okay. Perfect. We're going to talk about living wills too. Who in here has a power of attorney that they've spoken to and set up? Okay, about the same people actually. So kudos to those people. Okay. You'll notice that I didn't put up my hand for the will part. I do this. I've done this for 13-ish years now. I don't have a will, actually. I've got lots of legal stuff set up so that my partner is taken care of. But I actually haven't sat down and thought, okay, what do I need for this person? I know it's anxiety in me. I know it's existential anxiety. I've got all that intellectual knowledge and stuff around that, but I've also got a lot of anxiety around that, right? So I do have a power of attorney, and I've had very detailed discussions about what I want and what I don't want done, right? So I'm going to go back to power terms in a sec. Palliative care is also multidisciplinary, right? Anybody can do palliative care, right? And I think this is a super important thing to think about. Usually you think, okay, who are the docs who are doing it, right? I work in a hospital environment, so it's very doc-centric, basically, right? So the docs provide some of the symptom management. I'm one of those docs that provides this sort of psychological symptom management. But we include chaplaincy, social workers, OTs, the workers who are out there in the community every day, people who are interacting. You all have fantastic opportunities to actually intervene at a certain level and to reduce suffering. It's just a matter of how you think about the suffering, your ability to tolerate the suffering, to identify it, and to actually feel like you can do something about it, or, and this is a big or, that you actually can sit with it, right? Because a lot of times, the reason why we don't go to places is because we don't feel like we can sit with it. We don't feel comfortable with the emotions that get brought up by it. So, for example, again, if we're thinking about death, who's comfortable here talking about death, do you think? Varying degrees? Okay. Okay. So, if I was to say to you, randomly, you have stage 4 is the latest stage, metastatic breast cancer that we no longer have treatment for. And I'm sorry, I'm the oncologist saying this to you. Right? What's your reaction? Everyone can have a reaction, right?
Oh, for you.
Oh, for you. Any other reactions? Denial? Absolutely. 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 Pissed off. How can I get this? I take care of myself. I work out 6 times a week. I eat vegan food. Right? That's me. I'm sorry.
DNA, genetics, environmental.
DNA, genetics, environmental. I'm not sure.
Like
Causes, yeah. So you start thinking about the causes. You start running through your mind why this has happened to you, why it hasn't happened to you. Ultimately, underneath all of that is something that I would call existential anxiety, right? You're suddenly faced with this concept that we all know is there. We all know we die. We all know people who die. We've all experienced death in some way, shape, or form, directly, indirectly. As frontline caregivers, you've probably experienced it more than an average sort of person may have already. I think one of the key aspects of being able to do palliative care work is to be able to understand your own reactions to it, to be able to self-reflect about what your own reactions to it. Because if somebody starts to want to have a conversation about their illness, you have to be able to have that conversation about that illness. Whether that involves lots of screaming, lots of anger that gets directed at you sometimes, crying, hopelessness, whatever comes up, sort of from a mental health perspective. So the first thing that I'd like you to think about is your own reactions to death and dying, basically. Your own reactions are significantly influenced by your own previous experiences with death and dying. We talk about people having good deaths, not so good deaths, whatever good death looks like, right? Good death is typically thought of as sort of your peaceful, I go to sleep and I don't wake up in the morning. And it's sort of planned to some extent. Brendan, what do you see? I think the idea is that whatever experience you've had with death before has significantly influenced how you're going to look at death, right? So I'm thinking about my grandmother. My grandmother had, at 93, a stroke, a big stroke, because her family doctor took her off one of her medications that would have prevented that stroke from happening. The reason why he took her off that medication was because he thought that the antipsychotic that she was just placed on would put her at risk for fall. So he didn't want her on a blood thinning, basically, because he thought there was an interaction. I'm a psychiatrist. There's no interaction. There's no significant interaction. So she had a stroke. She had a big stroke. The palliative care doc decided that, because I was a doctor, that she would show me the slide, or the actual CT scan of the brain. Medicine me kicked in and said, sure, I'll look at the scan. Emotional me looked at this scan and went, oh my God, right? Because it was so devastating what I saw on this sort of scan that it took me like quite a long time to register what I was actually seeing there, right? So I sat down with my family, I'm the palliative guy, and I talked to them about sort of options. Interestingly, they didn't talk to us about options. I talked to my family about options. So, and we decided to discontinue life support for my grandmother, which basically meant discontinuing IV fluids so that she would die within X period of time. So we all gathered around her bed, and she died relatively peacefully over the course of 7 days. And we traded a lot of really nice stories, and we traded a few barbs as well, my family and I, and my family in between. So I'm telling you this story because that's my most direct, immediate experience with death that involves me, right? And it's a relatively okay experience from my point of view. The one thing that wasn't okay with me is in my decision-making, we decided to discontinue the life support. At some point, my grandmother, in her unconscious state, started to move her arm. My sister's a nurse. So my sister and I go huddle in a corner and go, shit, what's this all about? She's moving her arm. Is she recovering? She can't be recovering. Wait, I know she's not recovering from what I know intellectually, right? She's got this massive stroke. I've looked at the CT scan. But my emotional side says, oh God, have we made the right decision? I want her to live. Uh-oh, right? That's the piece of me that I carry to the next one, right? That's the piece of me that I know I carry to the next one. I'm very vigilant about how people make their decisions. I'm very vigilant about sort of people making decisions in gray, lots and lots and lots of shades of gray, right? And not in that way. Shades of gray that really have no good right answer, right? And I want to help you guys or have you guys reflect on how comfortable you are with shades of gray as well. Because when we hit this stuff, there's a lot of them, right? And your ability to tolerate shades of gray is going to be incredibly important as we go along. So, any questions, thoughts? Cool. Excellent communication is a hallmark of palliative care. You would think this would be a hallmark of all care, right? I would think that, right? But somebody had to actually write a paper to say, hey, this is what it's about. We try to do better in palliative, I think. And we try to do better because of what I just said. I think when we're able to communicate, we're able to tolerate what the conversation is. We're able to go there with the people who want to go there. We're able to tolerate our emotions. And the other skill is we're able to contain them while they're doing whatever they need to do. Communication also has to do with even a milieu, right? Again, I work in a hospital. It's a shitty place to communicate, right? Everyone's been in a hospital here. Everyone's seen a ward here. There's no privacy. It's very difficult. There's that invisible, that sort of very thin sort of fabric thing. That's the cone of silence or something, right? It doesn't work like that, right? Setting up the milieu is really, really important to help create a sense of security for the person. Who here does home visits? Anybody? Great. So you're already on somebody's home turf, right? So they have the home turf advantage. They're feeling a little bit more secure. It's probably you who's feeling a little less secure walking into that environment sometimes, right? Yeah. I can tell you stories about guns being found in people's houses and things. Communication actually starts the moment you enter the room, right? So when you enter the room, and if you look comfortable, then that's great. You don't put the clients at ease, right? If you don't look comfortable, uh-oh. If you're hairy, if you walk in and you've just finished something really, really difficult and you're sort of flustered because of that, people read people, right? People in these stages of life are exquisitely sensitive to other people, or they can be, right? They will read you. Everyone reads you, everyone, right? It's just a matter of how exquisitely sensitive they become. When they're in an environment where they've seen caretaker after caretaker after caretaker, they actually have these experiences that are sometimes very good, sometimes not so good. Guess which ones we tend to remember? Yeah, we tend to remember the not so good ones because that's what our threat protection system in our brain does, right? Where's the tiger? Let's not go back there. That's the important thing to remember. We also like to remember where the berries are, right? So that we can go back and get the food. But we tend to remember where the tigers are because that'll help us survive. So you're walking in to somebody who basically has their own preconceptions of who you are. It's your job to actually be in a very neutral place, to be in a place where you're understanding where your own emotions and affect are, so that you don't walk into this environment and you have a better ability to contain the other person if you're in containment of yourself. Okay? So when we're talking about communication, we talk about goals of care a lot. This is a big, big sort of concept in palliative care. What are goals of care? It's pretty self-evident. Yeah? Goals of care basically involve the values of the person. What do you value? What have you been brought up to value? What's important to you? What gives you meaning in life? What do you think is important as you continue to get more ill? Is it pain control? Is it quality of life? Is it length of life? How do your religious beliefs affect what you're thinking? How do your previous experiences with death affect your experiences? And we all know that people in the HIV community have a lot of experience with death, right? And we know that a lot of that previous experience is going to come up as maybe a re-traumatization because there's a lot of incompletely processed grief out there, or just too much grief to process, right? So we know that when some of our clients start to face these issues, they've got stuff in the back of their mind about how people have died. They've got preconceived notions about what's happening. They've already built some values in their system based on their previous experience, right? Our job is to try to assess what those are, to respect them, to challenge them a little bit when necessary, but to mostly respect and incorporate them in our care of that particular individual. Okay? So this is particularly interesting in light of the new Supreme Court decision around assisted suicide, which we'll get to at some point if we have time. The other thing I want to emphasize about communication, again, it's not just between you and the client, obviously, right? There's a lot of opportunity for broken telephone, right? There's a lot of providers, there's a lot of support, there's a lot of family. When people are sick, they're sometimes taking things in, their cognitive status may have changed, they're taking things in sometimes very clearly, other times not so clearly, right? So I think that what would be very helpful is if we thought about the various systems that we're operating in and how we're operating in those systems. So for example, if I'm sitting there talking to one of my internal medicine colleagues, I'll turn into a completely different jargon than when I'm sitting with somebody and talking about their family member, right? And then I'll switch into another different jargon system when I'm actually sitting with somebody and trying to discuss their values and discuss sort of their emotional reaction to what's happening. I know what I'm doing. I modulate that myself. And I think it's important that you notice when you do that. We all have our own basic styles of communication. We all sort of do this very automatically. What I'm asking you guys to do is become a little bit more mindful of how you do that. The reason for this, is because I can't tell you how many times I've actually seen a physician, I'm singling out physicians again, because there's a lot of jargon in medicine, go up to a patient and say, you've got a grade 4 metastatic lymphoma, and the patient's kind of going, oh, that sounds bad, right? And they don't explain what a grade 4 metastatic lymphoma is. They don't explain the sort of where it's gone, what's the progression, blah, 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 right? But they don't use simple language, right? So the other day I was in the Emerge and I heard a gynecology resident talk to somebody in the Emerge, another one of these private places, right? You've got an abnormal placenta and it's in the wrong place. I don't think I needed to hear about this poor lady's abnormal placenta in the wrong place, right? I just happened to be sitting in a waiting room and I thought, take her over there. There's like a private room like 3 feet over. Just do that, right? And I almost wanted to say that to this resident. And I have done that on occasion, but I didn't feel it was my place to do that because I was actually sitting there as a patient, not as a staff, actually. So I think this is important too when we're talking about communication. We talk about roles. I want you to think about what your role is, right? Why are you going in to see the patient? So a lot of times we're going in and say, oh, I have to deal with the housing for this patient, or I have to deal with the financial issues for this person, or I have to deal with the whatever for this person, right? The person is where they're at that moment, right? You have to actually be attuned to where they're at so that you can go there. And if you need to go to another place, you can help them come out of where they're at to go to this other place. But if they're in this place and they're staying in this place, your communication is going to be crappy with them, right? Because they're not where you're at, right? So, so impeccable, accessible communication also has to do with assessing where somebody else is at any particular point. And it's actually a really easy thing to do. You can actually just go in there and say, hi, I'm such and such. I'm here to talk to you about this. Where are you right now around that? It focuses them. Right? So Very much patient-centered focus, very much consideration of this circle of care as a whole entity again, not just the emphasis on one person. Okay, the domains of palliative care, I've talked about these already. I just wanted to make them very explicit. Pain control I list as number one because that's what most people think about, impeccable pain control. If you do not have good pain control, you're screwed, right? Because if a person's sitting there wincing in pain, they're not listening to a word you're saying. They're focused on this, right? They're focused on, right? It's terrible for them, right? So impeccable pain control is incredibly important. The other thing that's so important about pain control, there was a study done in the 1990s by a psychiatrist in Winnipeg that looked at suicidality and pain control. This is the other slide that I wanted you to be able to see, but of course it's like, oh my God, that's a mess. What I want you to get out of this slide is basically that there are actually two lines here and that both lines sort of track each other. So basically, people who have pain, and that's not very well controlled pain, actually feel like dying. We ask people, are you suicidal? And if they're in horribly uncontrolled pain, yes, I'm suicidal. You control their pain, their suicidality comes right down with the control of the pain. So that's why I put it as number one, okay? Control the pain, or if you're not in a position to control the pain, help somebody identify pain if they're in pain, right? Help them see that it's okay to display pain. Help them ask for help when they're in pain. If they can't feel assertive enough to say something, oh, I don't want to bother the doctor, he's too busy, blah, 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 blah. You can help them in terms of how they communicate with other people and give them confidence, right, in how they communicate with other people too. So quickly, symptom relief. We'll talk about some symptoms. Psychological function, which is my thing. We'll talk a lot about that. Social milieu and spiritual considerations. Okay. So pain control, we just talked about a little bit. The whole idea, again, of total pain that I mentioned previously is so important to take into account. So great, you've got the physical pain under control. The psychological pain we'll kind of get to in a lot more detail. The spiritual pain. What's the spiritual pain? What do you think spiritual pain looks like? Absolutely. So crisis of faith. God doesn't love me. God's angry at me. I was a good person all my life. Why is this happening? Right? So this is actually a very common phenomenon that goes on. I've been a very good person. Why are you punishing me? This is sort of the frequent thought that goes on. So we look at the people who don't believe in God. There's that kind of that crisis where, should I believe in God? Or should I believe in something bigger than myself? I need to find some sort of meaning because that's how I need to cope with this bigger than me situation, right? So other people who don't sometimes have religion feel quite bereft, right? They go through their own crisis of, what's going on, right? How do I make sense of the fact that I've got this, right? Do I blame myself? Do I blame the world? Do I take responsibility for what's going on partially? Anger is a very big thing that sort of comes out of this, right? And who here has been the object of a client's anger? Who here likes being the object of a client's anger? Who here has been angry as a person who's been ill, right? It's quite normal, right, to be on both sides. So spiritual pain, I sort of refer out to my colleagues in the sort of more spiritual fields, right? So if a person does have a particular religious belief, I usually refer to that person as sort of spiritual belief leader, whoever that happens to be. So we're lucky at Sinai. We have an incredibly multidisciplinary sort of chaplaincy service that is quite good at this and is quite well versed in sort of talking about end-of-life issues too. So again, the idea is that it's not necessarily all going to be your responsibility to do this. Sometimes your responsibility is just the identification of this so that you can call somebody for help, basically. Or you can tell the patient, there is help out there for this, by the way. So, so other symptoms, when we're thinking about HIV in particular, Medications are out there. Medications cause lots of side effects. HIV itself causes a lot of side effects. And I'm not just talking about HIV, right? As people have been on the antiretrovirals for extended periods of time, we know that they're aging. We know that, guess what? They get the diseases that everyone else is getting when they get older, right? So they're more prone to whatever. The cancers, the strokes, the whatever else comes with old age, basically. The other thing about the HIV meds is what we're learning about them over time is obviously they have their own toxicity, right? They have their own side effects, but they have their own long-term toxicity, particularly possibly around kidney function, particularly around cardiac function as well. And that can actually lead to some debilitating side effects as well, or some very bothersome side effects. So when we talk about other symptoms, we talk about this stuff, basically. And this is the quality of life stuff, basically, right? So fatigue is huge with HIV meds, right? Nausea, GI upset, diarrhea, that stuff is quite huge as well. Shortness of breath, not so much. This is more the cancers, some certain sorts of cancers. Weight loss is a big deal for people. Body disfigurement or changes in the body itself are a big deal as well. Appetite loss goes along with sort of the weight loss. There are treatments or interventions for all of these things at a number of different levels. So for example, weight loss, appetite, dietitians, for example, right? Is the person eating? Are we considering the financial concerns of the patient? Can they even afford food, right? Are they accessible? Can they get out of their house to get it? Are they too proud to go and ask for help to get it? Are they too proud to use whatever other resources there are for food? So we're thinking in a multidisciplinary sort of way when we're thinking about these particular issues. We're not just thinking symptom control, weight loss. Oh, I can give an antidepressant that causes stimulation of appetite that can cause weight gain, right? Yeah, I can do that. We can give marijuana. We can give people munchies. They'll gain weight, right? We can do that too. But we're also thinking about these other measures that are also very helpful in symptom control. Did I miss any major symptoms that people have seen? Yeah? Okay. So psychological. Big slide, lots of stuff. This is what I do for a living, basically. So this is part of the reason why this is a bit of a full slide. So we typically talk about depression, we talk about anxiety, we talk about trauma. Trauma is very important. Again, I've mentioned that there's the trauma of having had this epidemic be around for a long period of time, the HIV epidemic. Everyone, not everyone, but a lot of people have lost people, multiple people. There's trauma there. Confronting your own death is a re-traumatization of that again, right? I saw what Bob went through. Oh my God, I saw what he went through in the 1980s. That's my memory. That's my projection of my own future. Part of my job is to go, oh, wait a minute, it's not the 80s anymore, right? Part of your job can be this too, right? To give people perspective and reorient people and to challenge some of their notions about what is coming up. Existential anxiety is this other one that underlies religion that we talked about, right? It's this whole idea that we all know we're going to die someday, but we all put it on the back burner, right? Witness the number of people who have wills in the room or POAs. It's all in the back burner, right? But we all know this, right? You're going to die. Sorry. You're going to die. That's good. Existential anxiety flares at different times. That's why I'm bringing it up, right? And it flares mostly when you get repeatedly asked about sort of, what are you going to do in the future? What are you going to do in the future? What are you going to do in the future? I don't know what I'm going to do 10 years in the future, right? I don't know how this disease is going to progress. I don't know. I can plan. I can have goals. I can have hopes. I can have aspirations, but I don't know. The absence of knowing is what actually creates anxiety. The absence of knowing how we're going to die is a big anxiety for most people. They don't say, I'm afraid of actual death itself. I'm afraid of how I'm going to die is the refrain that people say over and over and over. And most of that is about pain. Most of it is about aloneness, right? Not all of it, but that's the repeated themes that I hear. Right? So part of our job is to make sure that we tell people about palliative care. We tell people that there are specialists who actually can support around these various areas. And not just specialists, family. We want to support family to support people too, right? So there's actually a whole psychotherapy called existential anxiety out there. It's very specialized. Very few people offer it. I kind of quasi-offer it. I do something else called dignity therapy, which is basically when somebody's at end of life, we do a life review with them. We actually talk about some of their great memories that they've had. We talk about things that they're particularly proud of in their life. We talk about their achievements. We talk about the way they've interacted with other people and what they're very, very proud of in terms of those interactions. We talk about their hopes and aspirations for the people that they leave behind and any special messages that they want to tell these people based on their experiences. We want people to transmit their wisdom, right? This is incredibly empowering for people.
You're validating their lives.
Yeah, exactly. Exactly. You're a human being. You're something well beyond just this illness. We want to make sure that we understand that, we validate it, and we remember it, right? Absolutely. Very powerful. So it's a very, very good point. Yeah, it is a risk. There's almost always something that people are proud of in their lives. There's always some little twist of something. And I think it's really important to consider it in the context of that person's life and to be able to feed it back to the person in the context of their life, right? So if somebody, for example, has struggled with chronic sexual abuse from childhood, has a lot of acting out behaviors, ends up with a lot of drug and alcohol use, ends up not being employed because they can't regulate their affect or they can't regulate their emotions. They keep getting fired from jobs because they're always angry, or if they're always anxious, they can't get out of their house. There's something there for that person that might be a little bit of a triumph. I was sober for 3 months, right? Something they're very proud of, right? I was able to talk to my mom about this issue, right? So that's the sort of context. Your point is, however, very well taken. I once did a dignity therapy with somebody, and it seemed to be perfectly fine when I did the vetting and blah, blah, blah. And this person spewed vitriol at this one person. And one of my jobs in doing this dignity therapy is to edit the document that sort of comes out, right? So I edited out about 98% of the vitriol. And then I showed it to the person. I said, by the way, this still seems very, very angry to me. Is that sort of the legacy you want to transmit? Is that what you sort of want to leave behind? Yeah, absolutely. You know, it's her life. It's her document. It's her legacy. I can try to modify it. I can try to help people see the perspective, but you know, it doesn't always work. I don't offer this to everybody. It's incredibly labor intensive. It basically is sitting with somebody, tape recording a session, which is about 45 minutes, transcribing the entire thing, going through the transcription, editing it so it all makes sense and holds together, sitting down with the person for another hour, re-editing, and then making up the document after that. So in total, it's about 10 hours per person, right? And I have a wonderful administrative assistant who puts up with me. And every time I hand her one of these tapes, she rolls her eyes and goes, so thankfully I have that. Cognitive changes, big important thing to identify, right? Cognitive changes are the loss of self, right? In some ways, right? Cognitive changes can range anywhere from sort of minor memory deficits to sort of much more major deliriums where the person isn't aware of where they are at or kind of what they're doing, basically. Under the context of cognitive changes, I think one of the big challenges that always comes up is capacity, consent, competence, those sort of issues, right? There are different people in the community who do competence assessments around financial issues. In the medical field, competence is determined by the physician who is proposing that particular treatment. I'm sometimes asked to say, is this person competent to say that they can take their meds or not take their meds? And I go, well, I don't know, that's your responsibility, right? Because to be competent, you actually have to understand the nature of the treatment, why the treatment is given, what the potential benefits are of the treatment, what the potential negatives are of the treatment, and you have to be able to say, yes, no, I understand and I accept that, right? The person who's proposing the treatment is in the best place to understand the side effects and all the other stuff, the progression and the possible benefits, and to explain to that person why they're using whatever they're using. I don't know why you're using this cancer regimen. Like, I kind of know, but I don't know what the side effects of this cancer regimen are, right? You explain that, right? That's not my responsibility, right? So medical competence is very specific. It's a little bit more difficult. There's some community people here. When people sort of want to do certain things and you kind of go, I don't know about that. That's making me feel really, really uncomfortable, right? Whether it's around financial decisions they're making or just really self-destructive behaviors or behaviors that you would question in terms of their judgments and sort of the person's safety and as they engage in these behaviors. I think this is a very important thing to sort of be aware of again, right? And if you want, any of these topics is like easily a 2-hour sort of talk, right? In a great deal of detail. I'm just sort of hitting the big things. Substance abuse, huge issue, affects retention, affects the ability to take medications, affects the ability to engage, affects the ability to even have safe housing. We know this, right? Huge, huge issue that we need to address. A lot of people don't think about substance abuse in palliative care. Person's got cancer. It's a 79-year-old granny. What should she possibly be doing? Right? It affects things, right? We need to ask the question. Coping. How do we cope? Everyone talks about coping. He's coping well. He's not coping well. What does coping mean? Anyone want to offer a definition? Good choice. Me neither. I'm scared too. I'll tell you the best heuristic I've ever found to think about coping. Okay? 3 kinds of coping that we almost all do. Problem-based, emotion-focused, meaning-focused. Okay? Problem-based, I solve the problem. Right? Whatever's in front of me. Emotion-focused, my emotions well up, they take over, I'm so angry, I'm so anxious, that I can't even think about solving the problem. What we need to do in emotion-focused coping is contain the emotion so that our rational brains can go to problem-based coping, basically. Meaning-focused coping doesn't get sort of pulled out that often, but it gets pulled out every time we have kind of big crises. This is the religious crisis, right? What's the meaning of all of this that's going on? You don't have to be religious to actually find meaning in something, right? I'm doing this because it makes sense because blah, 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 right? Meaning is incredibly important to all of us. Without meaning, this is when we get depressed, this is when we get demoralized, this is when we start to feel hopeless, right? So, you've just gotten your cancer diagnosis, you've just gotten your stage 4 metastatic breast cancer diagnosis, and you go into the stage of sort of, oh my God, how do I make sense of this? How do I make sense of this is invoking meaning-focused coping, right? What's the meaning behind this, right? Some people are able to take these crises and sort of spin them in such a way that they actually learn quite a bit about themselves and the situation, and they actually come out with a number of new skills and a number of new behaviors, right? That's optimal sort of coping, right? What most of us do, at least in the initial part of coping, is we hang on to what we have and we try to apply it over and over and in more forceful ways. It's like the person we see who's deaf or speaks a different language. What do you mean you don't understand? We raise our voices. We do the same thing with coping. We use the same thing. It's good to be able to catch when people are doing this, right? And you kind of go, well, that didn't work last time. Want to try something else? Well, that didn't work again. Want to try something else? Right? That sort of idea. Adaptation to change and illness adjustment. This is what sometimes people talk about when they think about coping as well, right? How good are you at this? And there's a personality characteristic called openness, agreeableness sort of idea. Openness to new experience. Openness versus closed, rather. Sorry, forget about the agreeableness. Closed people have a more difficult time adapting to change. Open people have a much, much more easy time adapting to new challenges and changes. It's not to say they don't go through their own processes, but they still have an easier time. Talked about being a burden a little bit. This is a big thing that's out there in the community, right? It's actually through the exploration that we can uncover people's sometimes very false assumptions, sometimes very real assumptions, right? It is hard work to take care of somebody who's lying in their own shit, right? It is hard work to wake up in the middle of the night when somebody's having a pain crisis. It is hard work to do that stuff. Right? We want to acknowledge that. Sometimes the flip side is also, yeah, it is hard work. Do you think that that person is willing to do the work with you? Is there any time in the past that you've helped them? How are you at accepting help? How good are you at accepting help? That sort of thing. A lot of people with trauma histories, for example, really hard time accepting help because you're in their personal space, right? They're very vulnerable. They don't like being vulnerable. They don't like people coming in. They'll actually push people away, even if it means they hurt more, they suffer more. They're used to this. This is how they protect themselves. So. Hey, some more psychological factors to consider. These are things that you can look at, right? Call them the 5 Ds. So when people are changing, these are the things to look at whenever they're undergoing any illness. So distance. So people move away from their relationships, right? These are signs and symptoms that something is probably not going on that's very helpful to them. Ask them, so how are things going with your friends? When's the last time you saw Bob? Right? Are you still going out to blah, 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 blah? So when's the last time you left the apartment? That sort of thing, right? Dependency, again, this fear of helplessness, different degrees in different people, really occurs in people with trauma. Really autonomous people. Western society is very autonomous, right? It's like we do stuff ourselves, right? Different societies are a little bit different around that. Chinese, my background, is a little bit more sort of socially interwoven, where you kind of have a lot of people helping a lot of people, and that's kind of the expectation and norm, to the extent that sometimes it's maybe too much help and too much interference, but there's all ends of the spectrum. Disability. Disability is basically, a lot of our clients are on disability already, right? We all have our life trajectories, right? We all have our anticipated life trajectories in our brain. Illness changes that trajectory significantly, and it changes it very differently depending on what stage you are at in your trajectory. So, for example, a 21-year-old who gets a life-threatening cancer is very different than a 93-year-old who gets a life-threatening cancer. It's not to say they can't be the same if the 93-year-old still has amazing goals and stuff they want to do, but it's going to be different generally because of what you expect a 20-year-old to do versus a 93-year-old to do. So part of this idea is just to kind of figure out what the achievement disruption is. So you've gotten this illness. How has it affected your life? How has it affected the way you see yourself? How has it affected the way you see your future? Disfigurement, huge, 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 right? Stuff doesn't work. Stuff falls off. Stuff is ugly, right? Our sense of self is very much based on how we project our physical bodies, right? Our sense of autonomy is very much based on what we're able to use in our bodies. We lose control of our bowel and bladders. It's a pretty private thing. We don't talk about bowel and bladders a lot, right? It's very embarrassing. It's very shameful for a lot of people to do this, right? So we want to be able to approach this with sort of this spirit of compassion, right? Compassion and caring, right? So again, this is being aware of how you walk into a room with somebody. So for example, if you're a nurse and you just took care of a really difficult patient in the next room, and then you rush in and you need to change the bedpan or the whatever of this particular person, and they feel all the stuff, the person in the bed feels all the stuff that you've just walked into that room with, they're gonna think, oh my God, is he mad at me? Why is he like that? I must have done something, right? People are egocentric. We do this, right? We scan ourselves and say, what have I done? So it's really important as a caregiver when you walk in again to be able to check yourself and know where you're at. as you walk in. Or I've done on occasion. I've sat with a patient and I've had a hard time regulating my own affect from the previous person I've just seen. I actually say to them, you might actually experience me being just a little bit on edge right now. I want you to know that it's not about you. I want you to know that I'm just having a really busy day and there's a lot of things going on in my mind right now. I'm still going to try to be present for you, but you'll feel this underneath. Right? I let them know what's going on. So, and that actually is my own vulnerability that I'm exposing, right? A lot of people feel like we have to be professional when we walk in. That's true, but I think part of being professional is actually being aware of ourselves as well. Death, existential issues, we sort of talked about that. So, how are we doing? Do you have any questions? Do you have any concerns? Okay. Social concerns, kind of pretty obvious. Financial concerns, legal concerns, wills, POAs. Somebody told me they had a living will. Living wills are great. Living wills are great because they sort of communicate what your wishes are if something happens. Living wills have limitations, two big limitations that I can sort of foresee and that I've experienced. One is you almost can never anticipate every situation that comes up, right? It's good to have the general spirit of what you want.
Mine's pretty simple. It's just DNRs.
That's great. That's actually incredible. That's a huge, big step, DNRs. Do people know what DNRs are? Do not resuscitate? Okay. If you're going to make a living will, make it relatively thoughtful and comprehensive, right? My living will is going to be like 200 pages if I do it because I know stuff that can happen. Living wills, the second point, they're not legal in law, right? I just wanted people to be aware of that because we've encountered that a lot in the hospitals. Yeah, it's the guide, and it's the guide on paper, and it's a wonderful guide. It shows that you've had that conversation or that you want to direct people and that you've thought about it yourself. So I do encourage people to do this. What am I to say? I don't even have a will. I don't have a living will. Take it as you will from advice from me. Food security, really important. If you don't have your basic planks, your physical security, your food security, your financial security, your psychological stuff is all impacted by that, but you can't get control of your psychological stuff if you don't have control of this stuff. It's really hard to do. So this stuff is really, really important. Housing security, care for the caregiver as well. Spiritual, we talked about crisis of faith. We talked about existential anxiety. I want to talk a little bit about POAs, power of attorneys. Do one is what I would suggest. Really do one. It does cause us to actually think about situations. It causes us to ask questions that are very difficult, like what will happen if I get in a really bad car accident? Do I want to live? Under what circumstances would I want to live? What's my valuation of my quality of life? Basically, that's the big question, right? What do I think? Is longevity more important to me? What are my religious beliefs that sort of dictate what I may or may not do? Do I agree with those religious beliefs? Things like this. So, when you choose your POA, choose that person wisely. They may or may not be your partner because your partner may not do what you want done, right? There's an assumption that our partners implicitly know what we want. Well, we all know in real life that that's not the case, right? There's lots of examples in your daily life where that's probably not the case. Why leave a big one to chance, right? Have the discussion. Choose somebody who you think is going to be in line with your sort of goals and can tolerate a lot of emotional stuff going on at any particular time. Or tell your clients to choose people wisely. Problem is some clients don't have people in their lives, right? They're very isolated individuals. PG&T is the next alternative. If you go PGT route, advise your client to do a living will. PG&T sort of is a very generic sort of institution. They are very conservative in terms of what they will actually allow or not allow. So it really is helpful if there's a prior express wish living will sort of thing, especially if there's a PGT involved. Yeah. So why is palliative care even important? I mean, I think I've sort of made this case, but there's lots of studies that demonstrate that there's actually better outcomes. Better outcomes measured by quality of life indexes, less depression, less anxiety, much improved pain control, increased feelings of engagement on the part of the individual and increased engagement on the part of the family. Lots of evidence that good patient-centered, family-centered, holistic, considerative care is very, very important. Right? Okay. And again, you might think, this is the care we're providing. Right? This is the care we should be providing. I think palliative care came into being because there's this umbrella of how do we take care of people in various stages of dying. We're lucky in the Western world because we have lots of resources available. There's a lot of places where those resources aren't available. Palliative care, in particular, its application to HIV across the world came into being because this is how people take care of people, right? They don't all have access to these drugs. Even if they do, they're not necessarily third, fourth, fifth, whatever line therapy, state of the art. People still die. We need to take care of people who are dying. We need to do it in a thoughtful and compassionate way. So, where does this happen? Right? It happens anywhere, right? Most of us think of palliative care wards, hospices, Casey House, it's a great place. It can be a mixture. Some people decide to stay at home and have people come into the home to care for them. Usually that stops when you can't get enough services to take care of whatever the physical or whatever other needs there are, and the person may decide to go into a palliative care ward at that point. A hospice, for example. There are some very nice hospices in Toronto. Casey House is actually one of them that's probably going to be based mostly for the HIV community. Kensington Hospice is lovely. Different palliative care wards, different hospices actually have very different feels. They have different philosophies, actually. So, for example, the palliative care ward at St. Michael's Hospital is very much a medical palliative care ward. Right? There's not a lot of psychosocial stuff going on there. There's some psychosocial stuff going on there, but if you compare it to sort of what I'm trying to do at Mount Sinai, it's not as much. So, specialized HIV inpatient units, these are becoming much more few and far between. I think the last one was in St. Paul's Hospital in Vancouver. I'm not even sure if that exists at this point anymore. And I think that's a good sign in some ways, because a lot of times those were there because there were so many people with HIV and needed such specialized care. It's a good sign that we don't need that quite as much now. Hospital, inpatient, outpatient sort of care, that's another sort of combination. Any combination thereof sort of happens. Usually what happens is people have crises, they end up in an acute care hospital, they sort of get fixed up, they go in the community. If they're too sick, they end up going to hospice or palliative care at that point. I think what the important discussion is, where do you want this care to happen, right? As much as we can accommodate you to understand what the patient's or a person's concerns and needs and wants are. This is my last slide. I put it out there because I think it's topical, and I think it's related a lot to this idea of palliative care. Rational death, rational suicide. I don't call it rational suicide because I don't like that term. I don't like the juxtaposition of suicide with the idea of somebody dying. Suicide is a different thing, in my opinion. And I just put one word, Supreme Court ruling, not because I necessarily have any great ideas about this or I need to teach you about it, but maybe to hear what your thoughts are about this and how it fits into, but it does definitely fit in. And we know we're in a very, very changing landscape around palliative care at this point, given the judgment of the Supreme Court. Do people know the judgment? It's been pretty topical for the last couple of weeks. Yeah, okay, great. The one thing I want to emphasize about the judgment, who here has read the judgment? Cool. So the judgment states in the last paragraph in the conclusion that the illness has to be grievous, it has to be irremediable, and that the person has to have a huge degree of suffering. That's not the word the Supreme Court used. They have to use unremittable suffering. And the court hasn't made it clear whether we're talking about just physical suffering, psychological suffering, or other forms of suffering.
My understanding was the person has to be still cognitively there in order to be.
Yeah.
So I'm confused because if they have gone through all this suffering and everything, they may not be cognitively there emotionally.
Okay.
So how are they going to be able to make a decision?
So cognition, it's a very good question, right? And I think it highlights one of the implicit assumptions that I find a lot in the hospital sort of setting. When I think about cognition, I think about it as a huge spectrum. And not only do I think about it as a huge spectrum of sort of you are very competent or you are not competent, but I also think about it as for what decision, right? So you can be very competent to manage your finances, but you may not be competent to do stuff around your medical decision making, right? So in a delirium, which is a sort of a fluctuating level of consciousness, if you're in that sort of hallucinating, delusional state and confused state, no, you're not competent. But delirium clears. There's episodes of clarity. So during those episodes of clarity, you can actually determine what the person's wishes are, right? If they're consistent over time. So, I agree, the person does have to be competent. They have to be able to say clearly that they understand, again, what this is, what the consequences of it are, what the consequences of not doing it are, and why they're doing it. So less of the why they're doing it. So we don't need to justify it. So the thing about rational suicide, and I'll just put this in very quickly, is a lot of people, again, get to that suicidal state or rational death because they are depressed, because they're anxious, because their tolerance for things is low, because they have a lot of bad pain control. There's a lot of stuff that can be done to actually help remediate this idea that you want to hasten death, right? There's a subset of people who actually have all of that, who still say, this is beyond what I was expecting, this is beyond what I want in my life. I'm fully rational, I'm not depressed, I'm not anxious, I'm okay with dying, blah, blah, blah. Please give me whatever. Right? I've already seen a couple of those people for psych assessments, and I've said, yeah, there's nothing psychiatrically going on with this person. Psychologically, there's a lot of thought process going on with this person. I can comment on that, but that's not a decision that I get to make for them. They get to make that own decision for themselves. So that's sort of my can stuff. Questions, thoughts?
I have kind of a specific question. The pieces that you were talking around working with existential issues and meaning making, is that like the kind of work that Viktor Frankl wrote about?
Yeah, Man's Search for Meaning.
Yeah,
Yeah, absolutely. Viktor Frankl was a gentleman who actually was in the German concentration camps. You probably know this story. During this time during the concentration camp, he had a lot of thoughts about sort of why is this happening. His sort of, the culmination of that is basically the book Man's Search for Meaning, which he wrote after he was released at some point. I read it hoping to find the answer. It's not there. It's thoughtful. It's sort of, the answer is basically, the meaning is sort of the meaning you find for yourself, basically. So it's a very, I found it a very dense book. I don't know if anyone else has read it. So, is that? Yeah. Existential crises, and I want to emphasize this again, it's not just about psychiatrists, psychologists, people, right? Existential crises are all over, right? Everyone can address existential crises at some level. So, this is my beautifully legible diagram here, right? Where in the spectrum do we involve? It's a very good question. It's one that doesn't probably have a solid answer. My stock answer would be involve early. Really, really involve early. So even if you're sort of at this point in disease progression, let them know that this other stuff exists. Let them know about symptom control. Let them know about caring in some other ways. Because a lot of people go into that problem-focused coping mode, right? The problem-focused coping mode for MS is, I'll beat this. Give me some whatever, right? Give me some Remicade, give me some anti-inflammatories, give me whatever the current state-of-the-art treatment is, right? Problem focused, right? The problem arises when you can't solve the problem anymore, right? Sorry, your HIV meds no longer work. We've run out of them. Sorry, we have no more chemotherapy for your cancer, right? To me, that point is too late, right? I would really encourage a discussion around palliative care before that. What we're trying to do in the field of palliative care is really address the stigma that palliative care equals death and dying in the last couple of weeks, basically, right? No. In fact, I can point out a number of examples where my colleagues, my palliative care colleagues, the physician colleagues, have been able to actually extend life well beyond what you thought possible because they have such impeccable control of symptoms, right? This person was supposed to have died of their cancer or their bowel obstruction, right? I see a stethoscope around your neck, right? Remember what you learned in med school? Never let the sun set on a bowel obstruction? That is not true. That's not true, actually. Bowel obstructions can go on for a long time. So that's what I've seen my colleagues be able to do. And the person still has quality because at that point they're interacting, they want to interact, this is important for them, they'll sit with bowel obstruction, blah, 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 right? So now, even though you give a person information, doesn't necessarily mean they're willing to take in information, right? And the way you frame that information is really, really important. If you mention palliative care and they've had previous experience, they go, oh God, I'm not dying yet, am I, doc? And they'll see me because they've had this spike of anxiety at that point, and they say, my internist told me I'm dying, they have me see palliative care. Good communication talks about how you tell somebody this, right? So you would say, you have MS, or however you're going to say you have MS, and you say, by the way, as your disease progresses, you're going to notice X, Y, Z, right? We're going to do our best to help you with X, Y, Z. But we're not just thinking about the physical X, Y, Z. We're thinking, you know what? Illness affects you, affects your family, affects how you think about the world and how you interact with the world. Did you know that we actually will have resources for you in the future that may help you think about these things? Just plant that seed, right? That'll help a lot down the road. Sure. I saw a guy yesterday who was congenitally deaf in my office. He had this fantastic little pad with 2 keyboards, and we sort of typed at each other. So the top was him and the bottom was him. So number 1 answer, technology. Number 2 answer, translation. Never assume somebody understands you, right? I can't tell you the number of times of actually being on a hospital ward where somebody's talking at somebody and I'm kind of going, you know English isn't their first language and you know you're using a lot of technical terms, right? They have no idea what you're saying, right? They're nodding their head because they're being polite and they don't want to kind of cause a ruckus. So translation is incredibly important. I don't know what the access to translation is in the community so much. I know there's a lot of private sort of translation. You all, or a lot of you probably belong to some sort of agency or institution. Those agencies or institutions should be able to provide you resources for that translation accessibility. Mount Sinai, for example, has a translation line. So they have a telephone that has 2 headsets. So you talk into one headset. There's a 3rd person who translates, and the other person just listens on the other headset. You sit with them, and you look at them directly and talk to them. It's awesome. It's a great system, right? So I don't know if that exists. But the more transparent the technology, obviously, the better. So, so the question is around the preponderance of medical, or the medicalization of illness, maybe, and how do we address that partly. I agree with you, right? I work in a big, huge downtown hospital. There's a lot of people running around who are internists and subspecialists at the yin-yang. I can't tell you how many times they don't communicate with me. I trace them down. Some are very good at communicating, don't get me wrong. Some are very, very good. Some just say, oh, you deal with that, right? I've done the piece, you do this other piece. That's sort of the philosophy that I actually take. You know, I'm very happy to take on this other piece. You deal with the medical stuff and I'll deal with the person. It's an imperfect sort of solution. I think the important thing is if you want to address this in terms of advocacy from an institutional level, talk to Casey House about sort of the shift of how things are going. I think that would be a very important discussion to have, actually. You can be the advocate for the palliative care, or you can be the advocate for, call it holistic care, right? If you want to call it that.
3 months to live in that.
Yeah, and that's unfortunate because, quite frankly, that exists out there too, right? The Tammy Lettner Center where I work, the cutoff is we expect you to live a year, and we'll take care of you during that year, right? So there's just some practical sort of boundaries that need to be drawn in that respect, and I think that sometimes gets confused with hard and fast rule and just sort of practical boundaries. So, but whatever you're doing, keep doing it. Like really, keep doing it. But if you feel like you're alone doing it, look around your institution. See if there are other people who are doing this, right? Because it can feel like a lonely job, right? I feel alone sometimes in the big hospital, right? I talk about stuff that people don't talk about, and medicine sort of kind of rolls their eyes at me and goes, great, glad you're taking care of that. Or they say, this is very important stuff, glad you're taking care of it, right? But they don't necessarily take care of it. So, sure. So if you just start, what kind of doc are you? Family doc? Okay. So the College of Physicians and Surgeons has these wonderful little kits for things, and one of them is on competence, one of them is on DNR. So we actually refer you to that. The quick answer, at least in a hospital setting, because that's what I'm mostly based on, I'm not so sure about sort of community practice, is that somewhere you have to document that you've had this discussion, and please document it very clearly, document what they said, document that they understood, document that they understood all the negative ramifications, not getting treatment, have them repeat it in their own, whatever you do, you have to document it, basically, right? You don't need a signature per se, it's already documented the conversation. Again, I can't tell you how many times in my hospital where I kind of go, I know you guys had this conversation, I was there for that conversation, where's the documentation? Somebody's going to look for that at some point. So, yeah. As long as you've clearly documented that, the college is going to be happy with you. So. Other questions, concerns, clinical cases?
Lee?
Great. Thank you very much.
Questions were answered? Yes.
Yeah.